Everyone. My name is Scott Hofer. I'm director of the Institute on Aging and Lifelong Health, one of the hosts of this colloquium series on displaying health data, cases, techniques, and solutions. I'd like to begin by acknowledging that we are living and working within the traditional territories of the Lekwungen peoples, known today as Songhees and Esquimalt nations, and the Wisanish peoples, known today as the Sarlip, Pakwachin, Sawat, Sekum, and Malahat nations. It's my pleasure today to introduce the two speakers. Dr. Basha Andraka Christo of the University of Central Florida will begin by presenting on nuances of information sharing and data display in a mobile application for students with substance use disorder. I had a chance to speak with her yesterday, and already I've learned a great deal from her experiences in developing, validating, and getting through the security review of this kind of work, and something we're involved in here as well. Following Basha's talk is going to be a talk by Shannon Tracy on optimizing public health surveillance through reproducible reporting, a response to opioid crisis on Vancouver Island. So we look forward to that. That will be starting at 2 o'clock. So, Basha, I invite you up to begin your talk. Thank you.
Testing? Okay. All right. Let me fast forward here. All right. Is this too loud? Can everyone hear me okay? Okay. It feels very loud from where I'm standing, like I'm blowing your eardrums out, so hopefully not. Okay, great. The title here is a little bit misleading because I'm not just going to be talking about a mobile application. I'm talking about an entire system that involves a mobile application, a student online portal, and then also a provider portal. So sorry about the confusion. But I will jump in first by just thanking the other institutions that have been involved in this giant project. First of all, Indiana University. That's where I started the project. At the time, I was a postdoc. And then it has been implemented there recently and is continuing. So that's our main home of the project. And one of my goals, fingers crossed, is that this project will expand to other universities, maybe even the University of Victoria. We'll see. Now I'm at UCF, so thank you at UCF for your support. EnfaGlobe was the software developer for all the software that we'll be seeing, as well as the animation. And I'll be giving you some video clips so you can see what I'm talking about. And then this was funded by Alkermes, which is a pharmaceutical company that makes medications for opioid use disorder and alcohol use disorder. And then finally, the principal investigator on this project was Jody. She was the one who was mostly in charge of the videos, and then I was the co-principal investigator. I was the one in charge of the mobile application and the portals. But obviously we helped each other and contributed. So the title of the project is Substance Use Navigation, or SUN for short. And if you want to learn more about the project, you can go to this website right here. So the goals behind this project were multifaceted, but really the reason I came up with this project to begin with is that third goal there, which is increasing student knowledge about treatments for substance use disorder. So I, for a long time, have been very passionate about students and other people learning about evidence-based treatments. So as you likely know, there's a lot of non-evidence-based treatments out there. So we wanted to first and foremost educate students about what is substance use disorder and what are the treatment options available. This then morphed into a couple of other goals, including decreasing stigma of substance use, period, with the idea that you're not going to seek treatment if you just feel stigmatized by having the disorder. And then it kind of branched from there into more of a health service realm, wherein we wanted to help students in the mental health center at Indiana University who are actually accessing treatment for substance use disorder, help them in their journey of recovery. So we decided to do that in a couple of ways that I'll discuss in a moment. But one of those was helping them track their symptoms and track their recovery progress, including their engagement in recovery activities. And then another was by having them share this data with providers. And I think this is really key because one of the issues that we learned after interviews with many providers at the University Health Center is that students typically will come in with these issues about once every 2 weeks for counseling. Ideally, of course, they would want to see students more frequently, but they're swamped, they have limited staff. So what happens often is the student will come in and they'll report whatever they're feeling or experiencing that day or yesterday, but they won't have a good sense of the last 2 weeks. And that's just, humans, we tend to focus on today, what's going on. So what we wanted to help the students with is tracking how are they actually doing over that time period when they're not in the clinic, and then likewise helping the providers have that data so that they can better support the student in terms of treatment decision-making and adjustment. Ultimately, the system was designed to have 3 parts, and I'll go in the next couple of slides into the development of this. What are some of the challenges we face, some of the solutions, and I'll also give you examples and take you through each of these parts in more detail. But basically, the first part is the student mobile application, and that's for students to track their health symptoms, things like their cravings, their mood, and then also their recovery activities. And then there's a student portal, and the student portal actually allows them to do the same thing in the event that they don't have a mobile phone, their mobile phone breaks, something happens to it. But in addition to it, it has videos, educational videos about substance use disorders and the treatments for substance use disorders. So going back to that first goal I had. And then it also has quizzes. And the quizzes, which I'll talk a little bit more about later, are really to see if these videos are efficacious in helping them understand what is substance use disorder and what are the treatments. All of this information can be shared with the provider portal. And so that's the portal that is accessed by the counselors at the Student Mental Health Center at Indiana University. And in that portal, the providers can see the data from the student portal, meaning did they go through the actual videos? Did they, what percentage of the video did they watch? Did they take the quizzes? What did they get on the quizzes? And then also the health data from the mobile application. I'll talk quite a bit about the provider portal of the 3 pieces here. The most difficult, in my opinion, was actually the provider portal because a lot of the assumptions we had about what providers would want or don't want didn't actually pan out. Also, the student videos, they took a lot of time. I would say actually the student mobile application, interestingly enough, was probably the most straightforward, but more on that in a little bit. As far as, I just wanted to point out kind of the intellectual property arrangement here, especially, as we hopefully plan to take this to other universities. So the mobile application and the videos are owned by Indiana University, but I know they're eager to share this. And then the portals are licensed from Enfaglobe, so Enfaglobe owns those. And the reason we did that is we didn't have a large budget for this project. So in order to have all the pieces, we had to basically build some and license them. So the process of development was user-centered and iterative. So that means we would constantly go back to the stakeholders to hear their thoughts, their needs throughout the entire process, rather than just, once doing it and then saying implement. This took a long time. It took 1.5 years, and, for good reason, because we went through over 12 focus groups, and, you have to recruit students for those focus groups and so forth. So I'm going to look at the different stakeholders here, but starting with the students, what did we do? So we showed them video scripts and we showed them feature ideas for the mobile application. in focus groups, got their feedback, modified, took it to the software developers, said, based on this feedback, create some graphical mock-ups. How might this actually look? You know, still shots of the videos, of the characters, still shots of features, took that to the focus group, modified it again based on their feedback, and then eventually did the animation for the videos with the music and so forth. And then the mobile application prototype, again, focus group that, modify that. And I'm actually not really showing you the full extent of the focus grouping here because there were a lot of focus groups in between. This is just the general process. For the providers, we found it actually kind of difficult to get focus groups of providers because these are working professionals at the mental health center who are just super swamped. So it was easier for us to do one-on-one interviews with them rather than scheduling a time when, you know, all of them could actually show up. And that was fine, just a slightly different process. So first we went and this is for the provider portal. First we went through a requirements gathering stage, again, mainly interviews, and we had a big series of questions, but if I were to just summarize the three categories, what do you actually want in the portal? What do you don't want in the portal, which was very interesting. And then how would you use this in your actual health service strategy right now? Where would this fit in? So then taking this information, we did mock-ups, prototypes, kind of similarly to what we did with the students, and then once again interviewed and ended up actually having a couple of, I would call them informal focus groups, much smaller than with the students, and further modified it. On top of all of this, we had an advisory board that we would meet with every month, and the advisory board was composed of both providers at Indiana University and providers in the community. And the reason we included providers in the community is that Indiana University doesn't actually provide all of the possible treatments. And again, to me, it was really important that students learn, especially about things like medications for opioid use disorder and alcohol use disorder, which are underused and stigmatized, but those aren't available at Indiana. So even though this was designed very much for Indiana, we wanted to involve community members so that the students could eventually be sent to those community members if, let's say, they watched a video, they liked the idea of a certain treatment, but they couldn't get it at Indiana University. So why this process, and maybe the better way to phrase this is, what are the benefits we saw of this process? Well, first and foremost, there were a lot of assumptions we had going in as researchers that didn't actually pan out. And so I'm very excited that we got this information on the front end rather than developing something that we took back to the students and providers and heard them say, I don't like that. So a couple of things that were, I guess, maybe surprising or particularly important. One was the tone of the videos. So there was, a lot of back and forth among the research team of, do we want them to be kind of funny, kind of silly, serious? How do we go about this, right? This is a serious, deadly disease or condition, but at the same time, these are students. We don't want them to feel like they're in a classroom and just watching this boring video. So a lot of the feedback that we would get from the students, both with respect to the characters and the words used and the music, was just striking exactly that right tone, which generally they wanted to be neutral with a hint of humor. That's kind of how I would phrase it. Then another big process was determining this guide character. So we had come in as researchers with a couple of ideas for guide characters, all of which were immediately struck down by the students. They ended up coming up with their own guide character in a series of focus groups. And basically they wanted a guide character that could represent the average student with no gender, no race, just nothing that is identifiable. And I'll show you an example of a video. What they ultimately came up with is a stick figure, and that stick figure wears a backpack just to say, this is a student. But other than that, everything from the color had to be neutral to, no features that might point to one gender or another. We also ended up doing animation instead of live action. And this is something we asked about from the beginning, and the students were pretty unanimous in that they did not want live action or people, because again, now you're putting a face on it, a gender, a race, whatever. And then also there was a sense that a lot of videos out there with live actors are kind of cheesy. So, ultimately for us though, animation was great because it's a little bit easier to tailor all these details when you're in control of the animation. The script was really, really important, and the big word that comes up here is trust. So students will not trust information if you present it in a certain way, if you present it as overly dramatic, or you present information that just goes against their long-held beliefs or values. So going through the scripts as a focus group was incredibly important here. It also allowed us to do things like tweak the language to actually sound like what a student would say, which is very important. A couple other just examples to show you why this was such an important process. So marijuana, we have a video on marijuana use disorder. Obviously, it's, not a good thing to have marijuana use disorder. It was kind of a negative video. One of the consistent points of feedback we got from the students is you need to say some positive things about marijuana. We're not going to trust this video if you say nothing positive. It's a medical treatment for certain conditions. And, until we put that information in, even in the form of just a few sentences, they didn't quite trust the content of the video. They also really wanted us to focus on the short-term impacts of the disorder, whatever the disorder was, versus the long-term. So we had started off in the scripts having a lot of information about, in the long run, it will lead to cancer, heart disease, whatever, you name it, but something like 20 years down the road. What they really cared about was the short term, and not even just health in the short term. So not just, I might have an overdose tomorrow, but also just impacts on relationships, on family, and on schoolwork. That was a really big thing that we ended up going back and adding that, coming to marijuana again as an example, if you do marijuana regularly, you may not have a great memory. And then if you don't have a great memory, you may not do well on exams. That was the kind of information that was the most salient to them, even though for us as researchers, we didn't think of that as at the beginning as being a very important piece of information to include. They also wanted some narrative style mixed in. So having some character, again, the stick figure or the stick figure's friend, talking about his or her own story. So it's not just this lecture feeling, but more of a, I'm telling a story about this hypothetical person and what happened in their life when they got this disorder. Finally, they wanted neutrality in terms of color and sound for the most part. I mean, sometimes we could, if there's a car accident, do like a car crash sound, but they really didn't want overly dramatic music because, again, it goes back to trust. That starts to make them feel a little bit like it's a DARE video. I don't know if in Canada you're familiar with that, but in the US we had this terrible DARE program that ended up not working, and the point was to scare people, young adults and youth, about drugs. You will die, your life will end, etc. And people just really nowadays react badly to that, especially if they had experienced that in their childhood, seeing those. So they wanted almost the opposite. So again, neutrality was very important. So that was some of the main feedback we got from the videos in the development process. Now I'm going to move into some of the feedback for the mobile application and then the student and provider portal. So the mobile application and student portal, again, this is to be used by the students, not the providers. So mainly we're getting student feedback here. So we had initially thought, okay, let's have prompts daily to answer things like your cravings, your confidence that you won't use, your mood, etc. Students said, well, I also want to have other things in there. I want to have a gratitude list, a free write journal, daily goals, and then resources. And with resources, they didn't just mean, like a website. They meant I want to be able to enter in my friend's name or my sponsor's name or my mom's name, anyone who might serve as a resource for me when I'm in a time of crisis. So we ended up adding those. We also had to ask them about the categorical answers. So, for the mobile application, some things were ordinal on a scale of 1 to 5. How's your mood? But then we also had some categorical answers, like what recovery activity or did you participate in, or what did you do for yourself today? And we had to find out from students, what are some things that you might do for yourself today? Exercise, meditation, etc. Obviously, we put in also, evidence-based treatments in there, but they wanted there to be a kind of a broader sense of recovery activities. Students also wanted access to this whole system even if they weren't actually part of the IU clinic. And that was an important thing that we learned, because students kind of go in and out of the clinic, right? They may end up not liking their counselor, and they don't want to just lose access if they leave the clinic, or maybe they don't want to go to the clinic for whatever reason, money, I don't know, but they still want to have access to the system even if they're not part of the clinic. So we had to navigate that in terms of the registration process to allow students to register separately from the clinic, but then again, from the software standpoint, once they join the clinic, to allow them to share the data with the provider. And I'll talk in a moment about how we do that. And then they also wanted the option to not share the data with the provider. So even if they are part of the clinic, maybe there's some things they don't want to share with the provider, or they just don't want the provider to see it at all. So from the provider standpoint, and I mentioned at the beginning, this was one of the more complicated pieces putting together, because the providers had a lot to say. So first and foremost, they very adamantly stated that they want to be the ones to invite the student. So not that the student happens to invite the provider or pick, one of our ideas at the beginning was you have a drop-down list of providers, you pick your provider and you share with that provider. Provider said absolutely not, because what if they ask me if I want to see the data and I say no? And they're already depressed. And now they go into a deeper depression because they think I don't like them, but I'm actually just busy and don't want to see this data. So from that standpoint, we decided we need to have the invitation for sharing initiate with the provider, and then the student gets an invitation and they can accept it. Also, and this really caused us to modify things, the providers were very adamant about not seeing free written or open-ended information. And why is that? Because they were super, super afraid of liability issues in the event a student were to write something that sounded suicidal. So if the student were to, in their journal, write, I'm thinking of killing myself, then the provider feels like they're on the hook. If they don't deal with it in the next 10 minutes, then maybe there's some liability issue. What if it's 3 a.m. and the provider's asleep, et cetera. So as a result, we really had to make those categorical questions completely closed-ended. We had initially thought of an other category where the student could free write it, and we just had to scrap that. On the other hand, the students themselves, though, wanted to be able to free write some things, as I mentioned earlier. So the way we navigated that is by allowing the sharing of closed-ended things, so ordinal data or purely categorical data that was, closed information you can add to, but not sharing any of the free written data with the providers. So the gratitude list, the goals, even the supports network of the student, did they add in their mom, their sister, whomever, anywhere that there is the potential of free writing anything, the provider said, we don't want to see it. So that data was not shared and is not possible to be shared. And I put a star next to this one because I found it kind of strange, and I just want to point out that this, may be very unique to this clinic, but there was this idea that they didn't want it integrated with their medical record because they felt, again, this liability concern that if the data from the system is integrated with the medical record, then now if they don't respond to it appropriately, then they might get sued. On the other hand, in other projects I've been on that are, developing dashboards, we've often heard people, especially physicians, do want it integrated with the medical record. So take this with a grain of salt. This may just be this one clinic. So in the end, we did not integrate it. We do have alerts included in the system for providers. So if a student has, mentioned, I think we did 3 days in a row that they have a mood of 1 on a scale of 1 to 5, there's an alert that pops up. So the providers actually did want to see those alerts, but again, there was this process of discussing the liability issues of what if they don't respond? What if they, the student keeps saying 1 out of 5 and then they go kill themselves? I mean, a lot of this was about suicide, actually. What happens to the provider? So the way we had to navigate this ultimately is by going to the university counsel, to the attorneys at the university, and basically getting in writing from them that you will not get sued if you don't respond to the alert. So in the end, we have the alerts, but there was this process that we had to go through to make them feel comfortable actually seeing the alerts. And then they wanted to see individual and aggregate student data. When I say aggregate student data, I mean of those students who have accepted their invitation. And the reason for that is that they wanted to see if there were any trends during the university calendar year. So for example, did the mood happen to drop just kind of across the board because of finals coming up? Or during summer break, did it go up? Almost like for their individual research purposes. So we ended up building that into their portal as well. As Scott mentioned earlier, we had a very tedious security review process. Definitely the biggest pain of the entire project was this. Probably the first was this. The second was kind of navigating these provider issues. But yeah, I don't know if this is typical at most universities. Again, we've only done this at Indiana, but it took them 6 months to review the system. That caused tremendous delays for us because this was an iterative development process, right? So if we gave them an idea, we just had to wait. We didn't want to go develop it, have them come back and say, we're not allowing that. So we would have just these periods of time, and I say 6 months like an aggregate was kind of the time if you were to add up the periods. They had us create this 500-row Excel sheet where we answered questions about every possible security feature. The software company had to do most of that work, provide all their backup plans, a bunch of other documents. This was very, very tedious. In the U.S., we have a law called HIPAA, and that protects healthcare, personally identifiable healthcare data that is shared during the treatment process. IU, though, wanted way more than HIPAA. So just as an example, HIPAA, wants you to do standard security passwords. So that would be 8 characters, upper, lowercase, special characters, numbers. But 8 characters is fine. Indiana University was adamant about 14 characters. So that's what we had to do. They were also adamant about not allowing students to save their password on their phone, which, if you think about this, is very tedious because this is a daily prompt you're responding to. So if you have to log in every day, and that was one of the pieces of feedback we got from the students, that's very frustrating. You might not use it as much. So we had to navigate this with the security gods, as we called them. And ultimately what they said is if the cell phone itself is password protected when you just enter the cell phone, then we can go ahead and let them save their password. If it's not protected, if there's no password to enter the cell phone, then they have to type in their password again each time, and again 14 characters at least. In the U.S., we also have a regulation called 42 CFR Part 2, and this goes above and beyond HIPAA for substance use-related data or mental health-related data. And what it means is that you have to get consent from the individual with every single provider to whom the information is shared. So in HIPAA, it's just fine if you've gotten consent or given consent, let's say, to your primary care doctor, then that primary care doctor can go and share it with other treatment professionals for purposes of treatment. You don't need to get consent from all of those other individuals. With 42 CFR Part 2, you have to get consent for all of those individuals. So again, how do you do that in the software system? You build in consent throughout the process, and so that's something we had to do. And, why do we even care here? Because sometimes people will see multiple providers at the university health clinic, and if they're going to collaborate at all, then, this process needs to be gone through for each of them. So the silver lining, the positive thing, and Scott was really making me think about this yesterday, is there a silver lining? Actually, yes. So we have a very secure system now, and that will allow us, if we modify it or take it to other universities, to just build on what's already very secure. I challenge anyone to find me a more rigorous security process at a university than what we had to go through at Indiana. So hopefully we'll never have to go through it again, and we just kind of build from now on what we've already created. So let me start off by describing the features, and then I'll show you the video. We'll do it that way. I have a couple of short clips. So in the student mobile application, we have the series of questions here that I've shown you. Again, the categorical ones, there's nothing open-ended, so the providers aren't upset. As you can see, we have this, what have you done for yourself today? There's a lot of discussion about how to even phrase this. This was something we went back to our advisory board with, to students. Should we call it treatment? Should we call it recovery activities? And there was a sense that we need to keep it very broad, because even though, doing yoga isn't an evidence-based treatment for opioid use disorder, for some students, that may help them. So, we had to, first of all, create a list of what are these categorical responses, but then also allow students to pick from things that aren't just those pure evidence-based treatments. And then I mentioned already some of the other tools we have that are not shared with the providers when the information is written into it. So let me just really briefly show you a clip of just a walkthrough through this mobile application. Let's see. So here, this is when the students would enter. They will every day get a prompt. They can set the frequency of the prompts when they occur. They'll answer questions. They get 7 questions total each day, and that was a very purposeful number. We didn't want them to feel overwhelmed. They answer, like I said, some ordinal questions about their cravings. How confident are they that they won't use? Again, this is to be really ideally shared with the provider. What have they done for themselves today? Very broad. We have medications in there further down the list. And then they submit this. In analytics, they can show the responses to, or they can see over time the responses to the questions. Oh, I think it just repeated itself. All right. And then here's the second video from it. So this is from a student who hasn't answered too many questions over a period of time, so you don't see too much data in here. They didn't say anything about medication-assisted treatment or support groups. But technically, if they had more data, they could see it over many months, days, weeks. Here, they can add in their contacts for, whether it's their AA sponsor or their mother or whomever. They free write that in, not shared again with the provider, because even just this, the providers were afraid the student might type in the phrase suicide or I'm going to kill myself even in here. So then we could have them, we actually preloaded some sources that we thought were useful for them, but they can also add their own sources into here. I think that's probably it for this one. Okay. All right, so okay, so one other point I'll make here, and then we'll see it in the portal. The students do want to see their answers over time, and so we allowed them to do that. What was difficult is to show them the relationship or the interaction between answers. So what do I mean? Let's say a student is every day exercising, and every day they're putting in their mood. They might want to see if on the days in which they exercise, their mood is higher or lower. Is this, a super valid statistical regression? No, but they wanted to see some kind of relationship. The tricky thing is that on a mobile application, it's hard to share that much data to show the relationships. And I'll show you what I mean when we get to the portal. So the solution we came up with here is that they can just see one variable over time on the mobile application, but if they want to see the interaction between many variables over time, then they need to do that on the portal, because then we have a much bigger screen to work with. So in the student online portal, as I mentioned, they have the same features as the mobile application. For example, if their phone breaks, they can see their health status over time and the relationships between answers. So the thing that was hard to show on the mobile app, we can show them graphically. Now, there was some discussion amongst the research team, should we have some statistical correlations? And our concern was, okay, A, what if we don't have a big enough sample size of answers, right? What if they've only been answering this for 4 days? And then B, will the students know statistics well enough? And we decided they will not. So instead, we're just showing them a graphical relationship, but we're not telling them, is it, statistically significant? And then there's the educational modules, and these have a pre-quiz, then the video, and then the post-quiz. And we made it in such a way that you have to answer the quiz questions in order to move to the next video. Why are the quizzes in there? This is for research purposes. We want to see if their attitudes and beliefs about substance use disorders and the medications have changed between before the quiz and after the quiz. This information is shared with the providers. They actually did want to see if their clients are doing these educational videos. So here you see what substance use disorders we're talking to them about, and then also the treatments. One comment I'll make on the substance use disorder videos, students were pretty adamant about, we don't just want a video about how drugs are dangerous, right? We know that. what they really wanted, and what I wanted from the beginning, is for them to understand what is a substance use disorder, right? So what are the symptoms that are signifying that maybe something has really gotten out of hand that you need to seek treatment. So a lot of the videos are just really focused on that. There is some information at the beginning about, yes, this can harm your lungs, et cetera, but what they really want to know is, how do I know as a student that I have an issue that I need to seek help? And then also there are reference documents that if they're sharing data with the provider, if they have that relationship in the system, then the provider can upload documents in there for them to look at. So let me show you now how the student portal looks. Just a couple of brief clips here. So this is where they would log in. This is the main page. Currently, it's set up so that only Indiana University students can log in, and that actually had to do with the security requirements from the security gods. But also, just for research purposes, we weren't really interested in collecting data from non-Indiana University students, although on second thought, I kind of wish we had allowed others in the community to use it. So again, they can just answer the same questions they did on the mobile app here. They have the reference documents, contacts, etc. If they have a relationship with a physician, a counselor, whomever in the clinic, then that'll be sent. And then here, this is where you can see this relationship between the variables that I was talking about. So you can see this graphically, and if you hover over a specific day, you can see your results for that specific day. Is this particularly meaningful to students? At this point, we don't know yet because we just implemented it. So they may think actually in the end, at the beginning, they thought, yeah, let's have this. I don't know. Maybe this will be too complex for them. We'll see. That's something we're interested in finding out as we're evaluating this. And then here are the educational modules. So this is how you enter. It shows what % of the module they have completed, including the pre-quiz, the video, and the post-quiz. So over here, they'll complete the pre-survey. And again, this is really for us to evaluate the efficacy of the video. It's not so much for them, it's more for us. Although they can actually see how their answers have changed between the pre and post quiz. So I'm going to stop this here, and now I'm going to show you 2 clips from one of our videos. So this is the one on alcohol use disorder and problem drinking. But again, we have other videos as well.
You've probably heard a lot about responsible drinking, but it's also important to understand the difference between problem drinking and alcohol use disorder. Let's start with how alcohol affects the body. Alcohol is first absorbed in the mouth. When it gets to the stomach, enzymes start to break it down. But most absorption happens in the small intestine.
So this is the beginning of the video, which is kind of, what does it do to your body? And then, as I mentioned, they want to know the short-term effects on their life and kind of more of that narrative style. So as you fast forward through the video, then we get more into alcohol use disorder.
I started drinking a lot when I met a person I really liked. When we broke up, I started drinking even more. In fact, it took more alcohol to feel good. And I started to drink during the week. I tried to stop, but couldn't. It was all I could think about, even though I felt really terrible afterwards. My friends stopped hanging out with me, and I didn't want to do things I really liked. Sometimes I slept right through my morning classes, and eventually I got fired from my research job. And scary things began to happen, like waking up in places I don't remember, and even next to people I don't remember hooking up with.
If someone with alcohol use disorder doesn't drink, they'll get withdrawal symptoms, including trouble sleeping, feeling shaky, irritable, anxious, or restless, or getting nauseous or sweaty. Repeated drinking can lead to alcohol use disorder, but there are other causes as well. Genetics can explain up to half of cases. Psychology and emotional state matter, including low self-esteem, depression, anxiety, emotional pain, and stress. Having friends or loved ones with drinking problems is also a factor, and people who start drinking heavily when they're young are more likely to develop the disease. Fortunately, most people who seek treatment can improve their chances of successfully overcoming this disease. Any questions? Ask your counselor.
So this was another thing the students wanted us to add in, is some responsible drinking strategies. But at this point, the video is already 5 minutes long, so we thought, okay, let's just put a list in. That was another point of feedback. The students didn't want terribly long videos, right? So let me see how I'm doing on time. Okay. Fortunately, I don't have too many more slides. So then we have the provider portal. As I mentioned, some of the features are the individual student data, the aggregate student data, seeing alerts, and then inviting students and sharing documents. And there's a couple of other features that I won't get into, but let me just show you a walkthrough of that as well. So here's where the provider can see the students who have completed or not completed the educational modules. Here's where they see alerts. And some of this has been slightly modified in appearance now. This is from a few months ago. So if the student has 3 days in a row of a really low rating, that's when it pops up as an alert, but I don't remember exactly. And that's something, we discussed with the providers of when do you actually want to get an alert. So over here, they can see the individual student data. They can also just go and specifically more into that one student, but this is kind of on a bigger dashboard. They can hide some of the students or see all of them if they want to see them all. They can hover over each and find out, on that particular day, what were the answers. Let me see here. So again, this can get very messy, which is why we allow them to pick and choose who they want to see. And let me show you the aggregate one. So as I mentioned, some of the providers specifically wanted to see, for all students, is there some kind of trend? Is something going on at the university this week, either finals or some sporting event or whatever? So this is just an aggregate of whoever their students are. Now, super statistically valid? No, because they're only seeing their own students whom they have invited and who have accepted it, but it's something they wanted. And then this is showing them the categorical data at the individual level, and then they can do this as well at the aggregate level. Let's see if there's anything else here that I wanted to show. Okay. And then we also have time ranges here that they can look over: a week, 2 weeks, a month, 3 months, and so forth. And part of the reason that we thought this was really important, having this sharing process, was we wanted the counselors and the students to be able to discuss what seems to be working or not working. So again, if a student comes in and today they're feeling bad, it may be, this is the end of the world, nothing's working. But the provider can look back at the data and say, I understand you feel that way today, but actually, according to this data I've been looking at, it seems like you're generally doing better, or on the days on which X occurs, you're doing better or you're doing worse. So we're hoping to see that this will influence the conversations. Now, the providers, they didn't want to feel like, this is making decisions for them. So that's not the idea here. It's more to promote these very useful, meaningful conversations. And as part of the research study, we are going to be doing qualitative interviews with both the students and providers, and part of that will be exploring how does the sharing of this data actually influence that relationship and influence that decision-making process. So this just started this fall, so I don't have, unfortunately, some fun results to share with you yet in a year. I would be happy to do that. So we are recruiting students for the study by having flyers around campus. The clinic is also reaching out to their own students. And then the Pan-Hellenic Council, this is, interestingly, the students that we had spoken with in the focus groups really advised going to the sororities and fraternities because I don't know if it's just stereotype or not, but I guess there's a lot of drinking that goes on over there. So they felt like that might be a useful place to promote this. So the students will get a $25 gift card if they do the educational module. That's including the pre and the post quiz. And then they use the mobile application daily for 2 weeks answering the 7 questions. And they can obviously use other features as well. And they don't have to share this data with their providers. We certainly hope they do, but again, you don't actually have to be hooked up to the clinic to use this. So we did want to have a a larger sample size. At this point, we're just really assessing feasibility, usability, acceptability. We're not looking, really at efficacy, except with respect to the education, to the videos. And for the treatments, we modified questions that have been used in studies based on the theory of reasoned action plan behavior. So we're seeing whether their intentions with respect to treatment changed before and after the video, their beliefs about the treatment, their ideas of social norms related to the treatment, and whether they feel like they can actually do it. So that sense of self-efficacy. For the substance use disorders, we have questions that have been modified from some studies about stigma. And so really that's what we're focusing on for the substance use disorder is, in this short little paragraph of a story about a student who, let's say they missed their group project deadline because they drank too much last night, because they have an alcohol use disorder. How do you feel about that student? So these are, modified from validated instruments. And what we're hoping to see is that the students, after watching the video, will have more of a perception of this being a disorder, having understanding, as opposed to, just getting upset at those people. And then I mentioned the qualitative interviews. So we started this in the fall, but as one has come to expect, there are always delays. In this particular instance, the delay is not the security board. It is actually the director of the healthcare clinic has retired, and we have a brand new one that just popped in about 2 months ago. So a lot of what we have learned is that you need very strong support from the clinic at the top level for those counselors to feel very comfortable and secure using this. So we are going through that process again now with the new director to make sure that, she's got her counselors on board and everyone's using it comfortably without having, again, those liability fears, et cetera. We don't want her to somehow make them feel like, you shouldn't use this or this is dangerous to use. On the other hand, the students who aren't part of the clinic, there's no issue there. They're already using it. So it's just kind of a delay on the clinic side at the moment. So I think that is my last slide. So thank you for listening, and I'm happy to take any questions or comments.
Thank you very much for your presentation. It was quite interesting. I was fascinated by the choices you had to make in order to render it. So my question is, I'll let the experts to talk about substance use. Mm-hmm. My question was, what plans did you have to monitor those providers, how they use that information about either individual patients or as a group? If I was fascinated by this idea that you monitor students as they watch the videos to understand what they're paying attention to. So I wonder if there was any plans or for feedback from the providers to understand what analyses or graphs or reports are useful, not useful, where you need to change, or we have to go against the grain and say, no, you actually have to look at this even though you didn't look at this before. Can you talk to that?
Yeah.
Please?
So, during the development process, we did have interviews and kind of informal focus groups with them. But now that it's been implemented, we have really two ways we'll be evaluating the providers and their use. So one is the qualitative interviews, where we'll be finding out things like, how do you actually use this in practice? How often do you use it? What are the barriers to using it, whether it's time or, some kind of pressure from the clinic. But we're also so the software company will also be finding out for us whatever information we want within the software, such as what are the features that are used most frequently, how frequently are they used on average, how much time a provider spends in that particular feature. And it's actually the same thing with the student data and the student portal. So we may find out, for example, that even though the students at the beginning said we want the gratitude list or we want, these resources, we'll be able to see, are they actually using it, how frequently, and so forth.
Basha,
Yes.
I really appreciate, great talk. Thank you so much. I really appreciate all the steps, the very careful steps you've went through in the design, usability, deployment of this. It really is excellent. We're going through some very similar things around cognitive assessment and a broader health research platform. And I've already learned a great deal from you. And although we're in advanced stages of development, we're beginning our security review. And so I'll let you know how that goes. I wanted to ask you, in terms of modifiability of the existing app and the back end, as this project evolves, as it might be tailored for other universities, is it set up in such a way that you can modify and kind of personalize this app to other mental health conditions, other purposes?
Right. So absolutely, that's something that we considered from the beginning, that we wanted this to go beyond Indiana University and that it's possible that other universities may have different needs. Again, a lot of this may be related to the clinic culture at Indiana University. So yes, it's absolutely modifiable. The only and this isn't even really a barrier, but I guess the only potential hiccup is just the intellectual property. So the portals that are owned by the software provider, that's no problem at all with them modifying it. The university, like I said, owns the video and the mobile app, but they also have made it, maybe not in writing, but they've made it verbally clear to us that they are fine with this being taken to other universities and modified as needed. So I feel confident that that would not be a problem. And actually not even just other universities. We've also talked about the idea of looking for a grant or some kind of funding mechanism to take this also into the community. Obviously, some things would really need to be modified, like the videos. They're very much student-focused. They look like students. They talk about classes. Our first step, I think, is to try to take it to universities, but I would also love to see this taken beyond universities.
Just one more quick comment. My colleague Jonathan Rush has worked in this area with me and others as well in terms of the kind of multivariate dynamics. And you mentioned that this is something that the students would like to see. They'd like to see that, on a day that I'm more physically active, I do things for myself, that my mental health is better. My cravings are less, this kind of thing. And to be able to provide that kind of on the fly in a dynamic way is perhaps an important way forward. Is this something that you see as a future direction for your app here, to actually do those analytics and provide them on the handheld? So that's something that I think at this point we've basically run out of funding for the current project. But looking back and I guess also thinking forward, if we were to get more funding, I would love to somehow work further on finding a way to fit what's currently in the portal, the student portal, also on the mobile app, navigating the small screen issues. And then furthermore, taking it kind of to the next level when it comes to the actual correlations, maybe even regressions, having some kind of more advanced statistical tool in there, but also kind of boiled down to what let's say an undergraduate student who's never taken statistics could understand. So I absolutely see that there is room for improvement, and I think we've really been seeing that since we've implemented it. But at this point, it's kind of a matter of money, as it often is, right?
I'd kind of be concerned that they would draw the wrong conclusions. I mean,
and that is something that we had discussed.
Researchers missee patterns or something like that. I'd hate to see someone untrained look at that, get the wrong causation interpretation or something like that in a fragile state. Do you have ideas of how to buffer that? So, I love the idea of sharing information, but with some kind of protection of...
Yeah, no, that's a really good point. And this is something that we have been talking about recently is, as I showed you right now, it's just on the student portal. They can see graphically the relationship, but nothing, more advanced than that. If we were to take it to the next level, we would really have to navigate that issue. And maybe one of the ways we do that is just by having it on the provider portal, because they're more likely as, PhD psychologists, at least at, that clinic, to have some ability to understand the statistics. And maybe that way they discuss it with the students rather, and they can do that buffer, that discussion of, well, here's the caveats, et cetera, versus just having the students see the statistics. But it's something that, if we were to move in this direction, I would really want to heavily focus group, both with the students and the providers, to kind of find that ideal middle ground. Yes?
Okay, that worked. Have you given thought to integrating this information with other information? because he figured that students are also, they may be monitoring their physical activity, and they may have another application, another piece of technology that they're using to monitor their diet. So if they're monitoring like 3 or 4 things and getting alerts on 3 or 4 things, it would be nice for them to be able to have a sort of an integrated view of everything they're monitoring, an integrated suite of alerts. And then finally, there's other, at least specifically within the area of substance use disorders. For example, I believe that there's various online supports from the AA program that people can access. So have you thought about interoperability of this with those other sort of self-monitoring, self-help supports?
Right. I love this idea. To be honest, I haven't thought too much about that, but I need to. I think there's a lot of tools out there that, why compete? We can always kind of help each other. What I have thought about is integrating just the research data with other data from the clinic, if they would be willing to share that data that they have about the students. Obviously, there'll be a pretty hefty IRB process, I imagine. But, like they have primary care physicians, for example, at the clinic. So maybe we could take this and integrate it with other data existing. But what you're talking about is integrating different apps. I think that's a really interesting idea. So something I will explore with the research team.
Basha, thank you.
Thank you.
So we'll just move through. So we'll just start by introducing ourselves. So my name is Shannon Tracy, and I'm currently a PhD student here at the University of Victoria in the Social Dimensions of Health program, as well as a VADA student. So I'm going to explain what that means in a few moments, but I'll let Marisha.
Sure. Good afternoon, everyone. My name is Marisha Gully. I'm a public health epidemiologist and also the manager of Population Health Assessment and Epidemiology at Island Health. And you'll see the relationship between the two of us as we go through the slides. So.
So today, actually, Marisha and I are quite excited to share our experience in creating reproducible reports, specifically to support decision-making in the the overdose emergency here in BC, or the opioid crisis. Just a little bit of context, this work was done as an internship that I did over the summer with Island Health, and so that's where the link comes from. And it is ongoing, and hopefully we can actually kind of continue the discussion at the end of the presentation for next steps and opportunities and the such. Okay, so just a little bit of an overview. I'm going to explain a little bit more about what VADA means and how we got connected. Marisha's then going to go into what's actually happening in relation to the opioid response here on Vancouver Island and Island Health's role in that. And then we'll get into the actual reporting itself. So background of VADA. So I mentioned I'm a VADA student. VADA stands for Visual and Automated Disease Analytics. And so it's a graduate training program that's put together by a partnership between the University of Victoria and the University of Manitoba, and a very interdisciplinary team of researchers. So we have computer scientists, there's health scientists, statisticians, that all come together to help train graduate students with different skills. So these skills are in technical and both professional. So technical, learning how to use R, Python, and Tableau. And from a professional standpoint, the responsible conduct of research and project management. So during class and summer school, we learn about these skills, but the real great part is we then get to go and apply them in a practice setting. So for me, I was really excited by the opportunity to work with Island Health, and just a little bit of background, I'm really interested in health systems and how we can look at resilience and emergency management within them. So when I learned that there was an opportunity to work with Island Health in the opioid response, I thought this was actually a really meaningful project. So that's where I'll let Marisha take over and start to explain what's going on there.
Thank you. So I just wanted to provide a bit of context for the work that Shannon undertook during her VADA internship with Island Health. And just to preface this by saying it's not meant to be a detailed or exhaustive summary, but is meant to highlight sort of the relevant context as it pertains to knowledge translation of the information that is needed to inform the response to the opioid crisis, and specifically for Island Health. And I'll say what I'm not going to talk about first before I launch into it. But so I'm not really going to speak about the details and not specifics of the data sources, but I did want to take a moment to acknowledge that the data we're referring to and the data that we're referring to are individuals and individuals' lives lost and individuals affected by the opioid overdose crisis. And I just wanted to share a quote from a former colleague, which was, "Statistics are humans with the tears wiped away." So I wanted to leave you with that as I go through. So this slide just illustrates the timing that in 2015, deaths due to illegal drug overdoses in British Columbia surpassed suicide as the major cause of unnatural deaths. And this next slide illustrates that the emergence of fentanyl in the illegal drug supply had a critical role in this increase. As you can see, the dotted line shows the illegal drug deaths that exclude fentanyl as a cause, and that dramatic rise between 2014, 2015, and continuing now today, due in large part to the emergence of fentanyl. And this graph just shows on the far right, in 2018, that the projected rates, illegal drug overdose death rates per 100,000 population are projected to be higher even in 2018 than they were previously in 2017. So that dramatic rise. And this next graph just shows the rates broken down by health authority, and it's hard to see because the Island Health rates do largely mirror the provincial rates in orange, so the light blue is sort of tucked under there. So I just wanted to provide a bit of context for anyone on the phone or even in the room who's not necessarily familiar with the context within British Columbia. So Island Health is one of 5 regional health authorities. An overall annual budget of $2.5 million, of which public health amounts to about 2.7%, if my numbers are correct, of the 2017-18 budget. And then the rest of that largely funding acute services, residential care, as well as community care and corporate services. So just wanted to highlight, we'll go into more specifically where we work within public health, but that the response to the overdose crisis across Island Health has been a collaborative effort across many different program areas. And as I was going through my notes beforehand, I realized that communications is not on here. They were a key partner in this response as well, and also critical as related to the data visualization and the knowledge translation piece. So where I work and where Shannon was placed for her VADA internship is within the Population Health Assessment, Surveillance, and Epidemiology team. We've now named it PHASE. And our work is to support the medical health officers and the public health program areas across Island Health through population health, related health data acquisition, information synthesis, surveillance, evaluation, and epidemiologic analysis, as well as knowledge transfer. And we work within the topic areas of communicable disease, stop HIV, AIDS, and harm reduction, chronic disease and injury, and specifically, as we're discussing today, the opioid overdose response. So what is public health surveillance, and specifically, what is public health surveillance in the context of the opioid overdose crisis? So it is the ongoing collection, analysis, and interpretation of data. Data originate from a variety of sources. We use those data sources to monitor trends, in this case with respect to overdoses, in order to identify at-risk populations that may have unusual disease burden, so in this case be most at risk for overdose or more specifically death related to overdose, and to identify specific risk factors that may warrant public health intervention. So the surveillance needs to be timely, it needs to feed back to those who provide data, and it needs to feed forward to those who can implement action, policy, programs, services, whatnot. So I just wanted to highlight some of the sort of key enablers with respect to the provision of data for public health surveillance around the opioid crisis. So many of you may know April 14th, 2016 was when the then provincial health officer at the time, Dr. Perry Kendall, declared a public health emergency. It's under Section 52 of the Public Health Act in response to the rise in opioid overdoses. And specifically for us, that means that allows medical health officers throughout the province to be able to collect more robust, real-time information on overdoses in order to identify immediately where risks are rising and take proactive action to warn and protect people who use drugs. In addition to that, there was a ministerial order established in December 2016 to facilitate the creation of the overdose prevention sites across the province, and then a provincial joint task force which has evolved to the Overdose Emergency Response Center, which was created in December 2017, so almost a year ago, and that's really enabled coordination and support and acceleration of data collection and analysis across the province. So how have we got some of this data as a result of those enablers? So under the Public Health Act, making overdoses reportable to the medical health officers means that hospital emergency departments report overdose events to public health, emergency health services, so ambulance, paramedics, through their systems. We receive reports of overdoses that they have responded to. Through an information sharing agreement with the coroner's office, timely toxicology results, and in addition, data from PharmaNet and data flow from our own overdose prevention sites and safe consumption sites, as well as harm reduction information. So I just wanted to summarize by saying that the data that we have are from multiple overlapping data sources, and often from data sources that were not set up for public health surveillance. And we have many different stakeholders and audiences, as well as multiple reporting requirements. So I'm just going to pass it over to Shannon now to illustrate the tools that she used to tackle some of these challenges. So, thank you.
Thank you. So I'm back online. I turned off for a second. Okay, so at this point, really getting into the report generation itself, right? And so Marisha highlighted a number of key points that are really important for this process. So there's a lot of different data sources that have some overlap, and we have different audiences that need this information. So how do we decide on the information that needs to be shared when we have so much, and how can we share it efficiently and effectively? So that's what we're going to kind of talk about here. So first off, Tableau was the software being used. Just trying to get a sense, is everybody familiar with Tableau? Raise your hand if you're familiar. Okay, so Tableau is a software that we use for visualizing, and the interface for it is like a menu-driven interface. So there's a couple of reasons why Tableau was chosen for this project. I mean, one, it was currently being used in this team, and BC CDC, as well as other health authorities, are using Tableau for dashboards and servers. So here's just a link. I'm not going to click on it, but if you are interested, that's the link to the public dashboard for the opioid response, or the opioid dashboard by BC CDC. And then there's also an internal, restricted server one, which health authorities have access to. So the other reason really is because it allows the integration of several data sources. And you can create the whole report within Tableau itself. And then finally, it doesn't matter which statistical software you're using. As long as you have the data set, you can import it in there. So it kind of eliminates personal preferences and access to stats. Once you have the data, it can be uploaded there. So the goal really when I joined Island Health and the team was to really contribute to the opioid response by producing automated reports using Tableau to enhance visual analytics and knowledge translation. So again, lots of data. We have different knowledge users who need different information to make decisions. So when I thought about this, I went, this is a knowledge mobilization or translation project. So really thinking about how can we make sure that the information that we are sharing with these, end users or knowledge users is actually what they want. And so this means it's an actual including actively engaging people from the start in this process of creating the reports. It also means it's iterative, so we are getting feedback throughout. And so when thinking about these reports, we can kind of map it to this process and to map what types of reports we're generating. And so when starting, there was a lot of reports to look at and kind of start to think of, well, where are some overlaps and how can we really start to think about this? So I know it's linear, but we have to kind of keep going back to it. So the first question is what? So what is the activity we're doing to share this information? Reports. When, how often does it need to be shared? Who's the audience? Who needs this information? Why do they need that information? What decisions are they making with it? And then that will inform the how. So what data we're including in the reports, and then how we're visualizing that information. And finally, we get to the measures, goals. Did we achieve what we intended to? So we want the information to have a use. And are we getting there? So here's just an example of what I mean when we kind of map a report to this process. Just one example, but there are several reports. So the first one is, so we have the surveillance update report. It's needed on a weekly basis, and it goes to the Island Health Overdose Response Emergency Operations Center. Why? This is for alerting purposes. So if something's outside of the norm, there's more overdoses than normal at a specific site, we want to be able to flag that really quick because the people receiving the reports are getting a lot of emails and have a lot of information to sort through. So we want to make sure that this information is being communicated effectively. So this actually informs the how, right? So we now know why we're sharing this information, get a sense of what they need it for. And now we have to choose the data sources. So we had 7 data sources to really work with, and everything from coroner's data to the opioid agonist therapy, and then starting to think of what variables we want to include. So that gets us to this. So here, back to the example. So in the weekly report, we used emergency department data, observed consumption services, and BCEHS, which is the ambulance data. And then how do we know we did what we wanted to? Well, from an internal perspective, for the team, we want to make sure that the process is more efficient, right? So my goal was really for the team to make sure that the process was, reducing the number of clicks to generate it. And then from an external point of view, or the knowledge user point of view, we want to make sure that the information is actually useful and used to help inform those decisions. So the visualizations have to be functional. So they have to be simple, understandable, and truthful, right? Okay, so on to the visualizations. My goal here isn't to go through each report page by page. I mentioned there are several. So instead, I thought maybe we could go through some of the different types of visualizations that were included, and then some of the little things that we did to make sure that we are communicating that information effectively. So and then, of course, a note, all of the data that I am going to be showing is randomly generated, and that's just for privacy purposes. So just keep that in mind when we're going through these. And you're going to see some funny trends that are fairly flat. So, it's not representative, but really just to focus on like how we created it and some of those tools that we use to make the visualizations more efficient. So the first thing that we did was we're creating a knowledge product, and perhaps it's advantageous to create a brand. And that first step is really creating icons. So we had lots of data sources, they overlap. We have lots of reports, so we want there to be cohesion between the reports. So icons were a nice way to do that. They were created in PictoChart, and each icon relates to a specific data source, right? Another piece here is color. So we want to make sure it aligns with Island Health. So we use the Island Health color palette, but also really thinking about how the colors we choose match with the data set we're looking at. So red is a high energy color, so we're matching it with ambulance data. And I'll get to it a little bit later, but also the icons and colors we choose and the language we use can have an impact on stigma. So what's our role in propagating that or starting to address it through reports? So just a couple of examples of how these were used. This is the cover page of a monthly report. And so here they're really used as a table of contents for what's to come and give a quick snapshot of what the main findings are. Another example, so you see we included the icon at the top. This one is for the observed consumption services, and made sure that the color stays the same so that as you cross through reports or in the same report, it is clear where this data is coming from. And then the other way in this example that we're using the icons is on the top of the table, right? And so if I were to walk through, I can't see it quite, but if I were to walk through one site, so one of the observed consumption sites, I could say how many overdoses happened there. Now, how many of the overdoses was naloxone given? And how many times was 911 called? Now, that's the extent of the information we get from this data source. But those icons can help trigger to go to the other data source to get the fuller picture and the fuller story of what's happening. So that's just some of the ways we thought of integrating icons. And then we have this one, very clear, or hopefully it's clear, but looking at the THN, so the take-home naloxone sites, by the little house icon, and then the THN kits distributed. And so that little briefcase is what a naloxone kit looks like. And you see that image in a lot of different places. Okay, so graphs. So one of the things that I think I knew a little, I expected when going in, but definitely got to appreciate a lot was epidemiologist currency is line graphs and trends and this type of thing. So we got to use a lot of these. And I don't want to go too much into actually what is being shown here, but really focusing on it. There are a lot. Trends are important, but they need to be simple and understandable. And one of the things in respect to the opioid response is these little triangles on the bottom are to signify the income assistant check week. And so this is something that's being reported by other health authorities as well. So we want to make sure that we're also matching up and there's cohesion between the different authorities. Another type of graph, so this is kind of 2-in-1. We have a stacked bar chart, but also it automatically re-ranks it based on the location where you have the most people being picked up to the least, right? Tables, so it shows your information, and this is really important for decision makers. But what we've added here is, I mentioned at one point, weekly reports are important for alerting. So if we see something outside of the norm, how can we flag immediately that, hey, there's something going on at this site, you might want to investigate it more. And so that's these automatic alerts which actually put that red dot behind it to flag when somebody goes through the report, hey, you might want to pay attention to what's going on there. It also allows us to validate that that's actually the case and look at the data a little bit more. Bubble charts. So this was kind of a request, actually. The individual wanted to see all of the different emergency departments and the trends, but they also wanted to understand that past month, which emergency department saw the most overdoses. So a bubble chart was a really quick way to convey that information, right? Heat maps, I think that's fairly straightforward. The darker the color means there's more people going to the emergency department on that day and time. And this one I'm a little bit nervous about because it's a donut chart. And I know people are polarized with pie charts. They either think they're useful or they loathe them. But the donut chart is a variation of the pie chart, so I'm not sure how everybody feels about them. So, the idea here is we were really trying to convey really simple information. How often was 911 called? Yes, no, unknown. Okay. So coming back to this process of creating these reports, so I said, there's lots of data, there's lots of overlap, we have different audiences, but we also have our own goals beyond communicating this information to the end user. Our goal was to also streamline this process, and so how we can do that is by reducing clicks. I'm not going to go too much into it, but here is one way to do it, is creating date parameters. And so it allows us to go backwards in time if we want to recreate a report. And then it also allows us, because it's a weekly report, it's being updated every week. We change these two parameters, and the whole report is changed, aside from maybe the cover page, which does have some textual data, right, or textual information. But that's one way we can actually start to streamline this process. So Tableau does allow us to do that, create the whole report with a few clicks. So just, again, a recap, overall, it's a really iterative process, and we are interested in making sure that the data that we're choosing is important for informing the decisions that the end users need to make. But also making sure that we modify as we go. So if somebody does come back to us, we do tweak it and change it and meet the needs of the people using that information. So there are some ongoing challenges and opportunities. I mentioned right from the beginning with the icons that we do have an opportunity here to also start to think about our role in stigma in the opioid crisis. And although we're not providing services ourselves, these reports are going to people who make these decisions. And so the language we use, the icons we decide on, and the colors we put in there can potentially make a difference. So really had to be thoughtful of that throughout, and we are still looking for feedback. And then another piece is dynamic, so dynamic versus static. Tableau, very interactive. You can explore different ideas and look at the data in different ways. But we're producing reports, so this is a paper document. It's pretty static. So really having to think of how do we show comparisons, and people don't have access to actually click through and explore it more. And then finally, the software. So is there an opportunity to move beyond Tableau? So we have things like ArcGIS, which might be better at making maps. Currently, Tableau, it can make maps, but there were certain features that we couldn't use in it. So what's the interoperability between those two types of software? And just to wrap up, really, this food for thought, and hopefully we can move into the discussion and possibly questions with this and questions for you. Most of this presentation, this presentation really focused on the internal audience. So people receiving the reports within Island Health. So how do we move that kind of conversation to an external audience or the public? And so starting to think about infographics, types of visualizations that can be engaging for different audiences, and then also distinguishing between what is new and what has changed. So hopefully we can continue that conversation now, but I first wanted to I'm very happy Marisha was here with us today, so thank you. And then also everyone at Island Health and the team, as well as VADA, so thank you.
I'm just wondering, is there the ability for somebody to say, here's a report I would like to see, so they could customize it? They could go in and say, here's what I'm interested in, and it would like generate a PDF and send it to them by email every week or something like that?
Yeah, that's a good point. So one of the things, Tableau, you have to have a license to use it, and the data is restricted to within our team. So for the audience that needs the information, one of the things is we have to make sure they're aware of what data is available. But then the other thing that I did near the end of the internship was create this dashboard that was for ad hoc requests. So if somebody were to see the report and say, hey, I actually really want to know about this, I want to know about whether it's like gender differences or age or any other type of question, we could actually go in there and make changes so you can actually zoom in on levels. So some of what we saw here is the main format we had was by HSDA, which is Health Service Delivery Area. And there's 3 on Vancouver Island, so South, Central, North. But some people might like to see it on a LHA, so local health area level. So there is kind of that functionality to actually change things, but it has to be done from us. Yeah. Thank you. Yeah.
Thank you very much for this presentation. When you spoke about choosing the color palette and the icons, it was music to my ears. Thank you. I feel validated that I don't think no longer do I think that I'm obsessing about choice of color. So thank you for that. I was particularly fascinated by the fact that you emphasized the importance of visual continuity across the reports. so that it's not only you can recognize what report I'm looking at by color you have, so you have multiple ways to reduce your cognitive load. You have color, you have icon to sort of to get that. I thought that was a really, really important aspect of graph making and presenting visual information. My question is, so you mentioned that there's particular graphs that are used in epidemiology, right? So the particular form. So I wondered if you started your project with, I don't know, 20 or however many different graphical forms, and you boiled down to 2 or 3 or 4 because you had to keep it. So can you comment on the graphs that didn't survive and it went into the dashboard?
Yeah, no, that's a really good question. It actually reminds me, about halfway through my internship, we went to a summer school in Winnipeg. And there was a woman there who did a presentation on visualizations. And she said something along the lines of, you have to recreate the visualization 10 times, and it might not be till the 10th one that the person that's getting the information, it resonates with them. So you have to be okay that it doesn't necessarily make sense. And so that was really important for me because I think before that I was working on the monthly report, and I put together these visualizations and I showed it to the team. I wasn't certain about it, and then I went away and I heard that, and I was like, okay, never mind, give it back. We'll put it on the side, and we'll try out new things. And actually, that was really helpful. I thought, got me thinking more creatively, bringing in new visualizations. So yes, I think that's the thing. It's iterative. You have to be okay with it not making sense and having to discard it, right? Even though it might take some time to create. Yeah. Thank you. Oh, that's a good question. Oh, I was asked, which of the graphs was most fun? Oh, you know what? Okay, so the one I was most proud of, and it was funny because it seems so simple. Where was it? This one. Yeah, so it's so simple. It's just a table, right? But really thinking about how those icons kind of like can play into it, and also making sure that everything in this graph is automated. That was a fun process to try to figure out how we can actually do that, because we're not just looking at the monthly count, we're looking at the total to date in this case. And then there's so much information in it, and really trying to make sure it's clear and simple. So I guess like most fun in trying to think of how much information I was trying to convey and simplify. But yeah, I don't know. I think I was happy with this one in the end because it linked to all of the data sources. Yeah, thank you. Yeah.
Terrific presentation, and I really like what you're doing and how you're moving the graphics out to really take in information quickly. I wanted to ask you about just how frequently are data like this updated? And with the idea of maybe embedding the analytics and automatically updating these figures, where are we with that kind of technology and the application within Island Health? Is this something you're working towards?
Yeah, I think I'll let Marisha speak to that.
So it varies by data source. Our own internal data sources, like our emergency department data, we have a daily feed. So we could, in theory, have a report that we clicked a button and generated a report on a daily basis. The overdose prevention site on a weekly basis, and most of the data that we have flowing through the province, through the BC CDC, on a monthly basis. So the examples that Shannon showed were from the weekly report, so that's sort of like the amount of data that we have updated weekly, but then the monthly report feeds in all of those other data sources as well. But the reference to the alerting, pulling those data sources together to create like a weekly alert from a few different data sources is sort of, it's to illustrate what's already happened, but we do look at the data more frequently. We just don't produce a report about it. So we have our anecdotal reports from the coroners, from the ambulance, from our sites, and then look, if something's flagged, we can look in our own emergency department data on a daily basis. So that helps.
You mentioned that you have a number of stakeholders from whom you're getting the data, but also to whom you are returning the data. So I wonder, did you find differences between how those different stakeholders wanted the data to look once it was reported back to them? So like in my presentation, one of the things I had mentioned is we had, providers and students, but each of them actually got a different thing in the end, right? One got a mobile app, one got a portal. So we didn't really have to navigate that issue, but it sounds like for you, all the stakeholders are getting the same report. So how did you deal with maybe some want this and some want that?
Yeah, no, so that's a really good question. And I'm smiling because, yes, that happened. And so, maybe I'll speak a little bit, and then Marisha as well. I think it really comes down to how people like to receive information, how they've received it historically, their training. So, in one instance, there's a particular user who really likes to receive everything in a table format. And so that's where you're having to go, okay, well, do we start to actually move away from maybe these more fun visualizations to something more practical that they can turn to? So, yeah, I think it was a struggle to figure out the balance.
Yeah, and there is quite a bit of customization that's happened as well, but the way that Shannon set things up in Tableau, we can have different versions within the same workbook, and so different versions of the same page. So it still has that continuity of the icons and sort of like that branding, but one might have a graph and the other one might have a table. So we have responded to that a little bit, reluctantly somewhat, but...
Yeah.
Well, it's sort of ironic, and unfortunately, I'm not a very visual person, and whenever Andre or anybody asks me, well, do the colors mean anything? Why did I choose those colors? And I just say, well, I like brightly saturated colors. So I'm probably not a good person to comment on any of this sort of stuff. And my question is not actually about the visualizations, it's about the content. I couldn't quite piece it together, but are you reporting overdose incidents, or are you reporting people who've taken overdoses?
Do you mind explaining what you mean by people who have taken overdoses?
Well, one person could take more than one overdose. So then you could have 20 overdoses, but only 15 people who've taken an overdose. So are you reporting overdose events that would sum across people? And did anybody ask about people?
Okay, so I feel like
Sure, I can speak to that.
So, yeah, particularly because if I saw repeat if I'm thinking in terms of outcomes, I would want to know about repeat overdoses, because if you've got a repeat overdose, then that's nature's way of saying that something wasn't working.
Yeah. So you're correct that we are reporting on overdose events, and in particular for our weekly alerting to look at those trends or any unusual activity with respect to events or clusters of events or whatnot. For the data that we have, for the most part, for our surveillance systems, with the exception of emergency department data, it is non-nominal, so we can't, through those systems, link and look at repeat overdoses or whatnot. So that would come in more of a detailed epidemiological analysis. And I think the hope is that with the reports and the systems that we've set up, we would be able to apply similar visualizations to those analyses down the road as well. And I think that's where some of the work going on provincially and elsewhere within the health authority and whatnot comes into play too. The other thing I'll add to that was just that, the comment about overlapping data sources, right? So people may show up, or events may show up in multiple data sources within the same week, right? So in the emergency department, ambulance, overdose prevention sites. So we have Shannon has made the effort to link those. So showing the proportion of ambulance attendant overdoses where people were transferred to hospital, and same with the overdose prevention sites.
So related somewhat to what Basha was asking, and that is, creating reports for different audiences. Somewhat related question. So operating in our universe, in our Markdown, there's a way to create different outputs, right? One is PDF, and one is HTML that allows for some interactivity. So I'm not disputing the choice of software. I'm trying to educate myself, and I wonder if generating print reports, automated print reports, was a priority, and how well Tableau is suited for that purpose. Is that a tool that is optimized for HTML canvas, or there's options to do print reports, automated print reports that could be a part of the products that are being generated by the surveillance effort?
Yeah, so I think that's a really important question, and that's why we just flagged at the beginning Tableau and some of the reasons it was used, because I understand that R can be used to automate a lot of reports, and it can be a very nice platform. But I think some of it really, in terms of the functionality of Tableau, is its output is a PDF. I don't believe it can go to HTML, but then there's those different levels, right? So if you have just a license, like an individual desktop license, you can create it, but then you can't really share it. And that's where the server comes in. But then the limitation there is how many licenses are actually available to access it. So that was kind of some of the maybe different, the considerations that kind of have to go with the limitations of Tableau. And I think you are right. It's that interoperability piece at the end, is there opportunity to actually move beyond Tableau? And also thinking about the skill sets and the users, because there was an example, another team had a report where they were making their visualizations in Tableau and then copying and pasting it into a Word document. And so we said, oh, well, hey, we're doing this all in Tableau. Why don't we help you move it into the Tableau interface, right? And so I think there are opportunities potentially to start integrating it, but also being aware of where everybody else is at as well.
Yeah. And I just wanted to add to that this is just sort of one of the tools that are being used, and the restricted dashboard that the BC CDC has set up for this purpose does offer that more interactive perspective, and that sort of to a limited number of users, but sort of to the same group for more of that customization and whatnot.
So it's not like the paper reports are ignored or hard copy reports are ignored, right? They serve a different purpose. It's a different purpose, yeah.
Good. Okay.